I'm ready here. This is Andy Pollack speaking. I want to welcome commissioners and members of the public. This meeting is the first remote-only commission meeting. This meeting is permitted under the commission statute, which talks about members present and voting. There's no restriction limiting presence to being present in the room. Present remotely is being present and is something the commission has done on a more limited basis for some time now. Given that this is a remote-only meeting, some additional ground rules will apply. I'll begin each meeting, including this one, with a roll call of commissioners. During the meeting, I'll ask that people speaking identify themselves before speaking. That way, commissioners and members of the public will know who's talking and have the same knowledge as if the meeting were in room 100. All commissioners are unmuted and may speak. The public and staff are in listen mode only, except for the staff who are in the room right now, sitting 6 feet apart from one another, at least. Due to the possibility of background noise, we do ask that commissioners mute their phones when they are not speaking. At future remote-only meetings, we will post documents that will be acted on and discussed a day in advance so that members of the public will have time to download them before the meeting begins. We'll provide advance notice of how to dial into the meeting by posting that information on the commission website homepage and our various social media channels. Are there any questions from anybody with regard to that? Hearing none, I'm now going to call the roll. Commissioner Boyer.
Attending.
I hear Commissioner Boyer. Commissioner Boyle. Do I hear Commissioner Boyle? Not yet.
Do you hear me?
There you go. With an echo, but I heard you. All right. Commissioner Bandari is attending but not voting. Commissioner Bandari, are you there?
He is online, but he's not, he cannot communicate yet.
He's muted. Okay, good. Commissioner Dordan, are you there?
He is not online yet.
Commissioner Dordan is not present yet. Commissioner Metz, are you online?
Commissioner Metz is present.
Thank you. Commissioner O'Connor. Jerry, are you there?
No, he's not.
He's not online. Okay. Commissioner O'Grady.
Yes, I'm here.
Great. Commissioner Reimer, I heard you previously. Commissioner Sargent.
Yes, thank you.
Yep. Commissioner Sargent, I heard you previously.
I'm here.
Commissioner Wang, are you there?
I'm here.
Good. Are any other commissioners on the line whom I didn't call?
This is Commissioner Hammersley.
Excellent. Anybody else?
McCarthy is here.
Excellent. So I believe we have a quorum then. Is that correct, Sue Ellen?
Were there 8 commissioners who said yes?
Yes.
Well,
Yes.
then we do. Then we do.
All right. Excellent. All right. Next up is approval of the minutes. I will entertain a motion to approve the minutes of the February 20 public meeting of the Commission. Do I have a motion?
So moved.
Second.
Commissioner O'Grady made the motion. Who seconded?
That's me, Randy, Commissioner Sargent.
Excellent. All right. All in favor?
Aye.
Aye.
Aye. Aye. Aye.
Is anyone opposed? Hearing no opposition, the motion passes. Commissioners have received written updates from our centers. Commissioners, do you have any questions on the written updates? Hearing none, does the executive director and any of the center directors have additional updates?
Dr. Pollack, I have an update. My update today is going to focus principally on the response of the MHCC to the COVID-19 pandemic. Our major responsibility within the framework of state government is to assist with other agencies in the private sector in expanding our hospital bed capacity. We are working with other state agencies, the MHA, in addressing those issues. They focus really on the major challenge of identifying up to 6,000 additional hospital beds by early July, when the pandemic is thought to peak here in Maryland. We are doing that both in the broader group and within the Healthcare Commission by focusing in this priority order. First, on existing bed capacity that can be brought online quickly at existing hospitals. Second, space that can be built out quickly and brought online in the next 3 months. And a good example of that was the recent emergency CON issued yesterday. And then third, space at other healthcare facilities that can be converted to inpatient beds that is of sufficient scale to make a difference. I think that's important, that there are lots of healthcare facilities that could provide beds in the volume and the magnitude of a micro hospital, but really we need to be focusing on those entities that can provide a significant volume of beds equivalent to a moderate to medium to large acute care hospital. And then third, non-hospital space that can be retrofitted to serve as a hospital during the pandemic. And that is, the sky's the limit in terms of what could be considered. We're trying to think outside the box. That it could include hotels, educational settings, etc. So clearly right now we're focusing on priority 1 and 2. There's also a surge group that's focusing, you can get the beds, but you need to also consider staffing. A group of folks within the health department and outside are focusing on staffing needs. And you've already heard what the Governor Hogan said in terms of trying to make additional staff more available by relaxing licensure and relicensure requirements, deploying certain healthcare personnel to hospitals from facilities that currently may not be needed or are closed, identifying nursing students and other students that can be deployed with the appropriate additional oversight, and then recruitment of healthcare personnel from outside the state that can be brought on a temporary basis. Clearly that latter category is going to be a difficult lift because as the pandemic is now in every state, personnel are going to be needed within that entire, each of those states. President Trump has already mobilized the public health corps, but there are other potential options longer term as well, including military health personnel. We're also working on a secondary role in terms of equipment and supply. The state has committed its purchasing capabilities to assist facilities in acquiring needed equipment, all the from equipment such as personal protective equipment, all the way up to respirators and everything in between. And then the state is bringing on additional project management and project coordination personnel to assist with facilities in putting all of this into play so that capabilities and equipment can be brought to bear on the pandemic itself. I want to focus on the surge capacity that we view as our primary challenge. That's our meat and potatoes issue on a day-to-day basis. And we, first off, are relaxing those requirements to meet this important challenge. First off, in terms of unused physical bed space that can be brought back online fairly quickly, MHCC and OHCQ have agreed that the Commission does not need to take any action if an acute general hospital is trying to bring back unused physical bed space for service during the pandemic. Under its regulations, OHCQ already has the ability to approve increases in the hospital's licensed bed capacity. That's typically done during the winter months of the year when many hospitals need to temporarily increase their capacity due to flu sickness in their communities. We believe, and OHCQ agrees, that this authority can be expanded and consistent with the governor's executive order and state of emergency. We've told OHCQ to move forward with all undue speed to make that available, with the understanding that these temporary bed increases would be authorized through the pandemic up through 30 days after the governor's termination of the state of emergency that he declared early this month. In terms of emergency CONs, as you know, I issued a letter to hospital executives on Tuesday night informing them that MHCC can issue an emergency CON to address this pandemic. Consistent with our regulations, longstanding regulations, something we didn't need to create as a response to this, but one we hoped we would have to use only infrequently. Now, if is certainly a situation where we need to take advantage of that authority. Under that authority, I can issue an emergency CON after consulting with Dr. Pollack and after I've received appropriate information from the Office of Healthcare Quality regarding the need for prompt action. We have committed internally to turn around these emergency requests within 24 hours of receipt of an application. There is, I want to be absolutely transparent about this, that there is some initial back and forth before anything is sent to us, so that the applicant has resolved any questions before paper is exchanged, so that once it's in our office, we can turn that around very quickly. The information, unlike the CON application that we routinely use, will require only a limited amount of information, description of what the space is to be used for, where it is to be located, what the project, when it's expected to be brought online, and the approximate cost of this particular action. The emergency CON will be valid through the pandemic and 30 days thereafter, but I have the ability to extend that for a good cause. We think that most of the emergency CONs that we will issue would be concluded with the end of the pandemic, but we are allowing the ability of an applicant to convert space that was converted on an emergency basis to a permanent expansion in capacity, but that would require a CON. That CON would be due 30 days after the termination of the state of emergency, but that too can be extended at the discretion of the executive director. So we think we have the ability to act very quickly. The most important thing is in terms of physical space. We are encouraging healthcare facilities to act with all due speed to bring back physical capacity that has been taken offline. That does not require any action on the part of the Healthcare Commission. We will be exchanging information with OHCQ electronically to ensure that we have a good idea of the additional expansion that we expect to be coming online relatively quickly. In terms of staff itself, like all agencies of the state government, we are only essential mandatory staff are in the office. That typically on most days includes 4 or 5 staff members. Today there's a bit more, but it is below the 10-person limit that the governor has required organizations to keep below. Staff are continuing to perform their normal functions. Those that are performing COVID pandemic initiatives are tracking their time because there is an expectation that the state would be able to potentially seek reimbursement for some of those activities from the federal government, although there's no clear guidance at the present time about that. Some people in the room may not have heard that yet, but we're sending out information on how our timekeeping systems can be adjusted to track those time commitments appropriately, so the state can be reimbursed. Lastly, in concern, my utmost concern is that staff all are healthy. We are trying to maintain some levity in what is probably the most challenging situation of our lives, and recognize that through our tele and virtual communication capabilities, we're going to keep in touch with everyone as well as the commissioners. I'll stop there for questions.
Are there any questions for Ben? So hearing none, I'll just make a couple of comments. First, I want to express my thanks, and hopefully we'll do it more than once today, but express my thanks to the staff for their ongoing hard work in what Ben has described as a very challenging time, probably one of the most challenging that we faced. And I think that is a testament to the very privileged life that we live in this country, that we've never faced a challenge like this before. I would also say that having played a major part in a similar but different challenge in Haiti about 10 years ago, just a little over 10 years ago now, I can tell you that the other half of this, the half where the medical problem frankly exceeds the capacity of the healthcare system to address it, is much more difficult than what we're in right now. What we're in right now is a ramping up situation and a response situation that will hopefully prevent us by social distancing and other measures from ever getting into a situation in the state where we have to decide who's going to get care and who's not going to get care and who's going to live and who's going to die. Those are exquisitely difficult challenges, and I would say that outside the developing world, it's extremely rare that people are ever forced to face those types of challenges, and hopefully that will never happen here. But the tremendous efforts of the staff right now and others throughout the state are what will hopefully prepare us best to handle that if and when that were to occur. So thank you to everybody who's working so hard to prevent us from getting into situations like that.
Dr. Pollack,
yes.
I've been told that Commissioner Jordan and Dr. O'Connor are now online, although they may not have voice capabilities just yet.
Okay. Commissioner Jordan or Commissioner O'Connor, can either of you speak? Not yet, but we understand you're online. Moving on, before we consider action items today, I want to remind commissioners that if they wish to recuse themselves on any action item, they should inform the chair and recuse themselves from speaking any further. My notes say move to the MHCC conference room. I would suggest that you not do that. Staff will let you know as soon as the commission has completed action on that agenda item. So I will let you know as well. Action item number 3 is a certificate of need for Baltimore Detox Center, LLC, to establish an alcoholism and drug abuse intermediate care facility. The commission has 2 CON actions on today's agenda. This first one is for a drug rehabilitation intermediate care facility in the Woodlawn area of Western Baltimore County. This facility, if approved, will provide medically monitored intensive inpatient withdrawal management for persons with substance use disorder, primarily to private paying patients. Kevin McDonald, Chief of the Certificate of Need Division, will summarize the proposed project and present the staff's recommendation for the commission. Kevin?
Thank you, Mr. Chairman, and good afternoon, commissioners. As Dr. Pollack stated, the proposed project would establish a 24-bed alcohol and drug treatment facility, intermediate care facility in Woodlawn. it would be a detox or withdrawal management only project, and it is track 1, which I'll remind you means that it is primarily private pay patients. However, for this project, unlike the recent track 1 facilities the Commission has seen over the last couple of years, this applicant does plan to include services for Medicaid patients. The applicant is Baltimore Detox Center. It's a proprietary corporation. It's owned by MBM Ventures LLC, which also owns Amatus Health LLC. Amatus Health is the operating arm of the organization, and operates a series of treatment centers owned by MBM Ventures, which has an ownership interest in 12 centers providing withdrawal management and/or other substance abuse treatment services in 6 states, including 2 in Maryland. All of these facilities have opened recently, with the oldest beginning operations in May of 2017. The applicant proposes to convert a building in which MBM or Amatus currently operates an outpatient recovery center, and they would convert that building to a 24-bed intermediate care residential treatment facility. If the project is approved and they go ahead with this project, they would move their outpatient treatment facility that they currently operate in that building to another location in Owings Mills. Cost of the project is about $586,000, $225,000 of which would be working capital for startup costs. The project would be financed with cash. Before I go into the discussion of performance against the criteria and standards, I want to give you some notes on the procedural aspects of this review. The proposal underwent a number of changes as it wound its way through the review process, which delayed its consideration. In addition, Maryland House Detox Center, a track 1 intermediate care facility in Linthicum, commented on the application and sought interested party status. Commissioner McCarthy was appointed as the reviewer, and he granted Maryland House interested party status. When Commissioner McCarthy took leave of absence from the commission, Commissioner Boyle was appointed to continue the review, and she jumped in with both feet. I think she read most of the application on the Acela on the way to visit folks in New York City. She and the staff discussed a number of inconsistencies and problems with the application and determined that a project status conference would need to be held to give the applicant the opportunity to make the changes that would be required to make the project approvable. However, at just about that time, the interested party withdrew, and the review then reverted back to staff, which held this status conference in late February. The applicant made the necessary corrections and modifications. In looking at the need for the project, the need formula in the state health plan chapter projects a net bed need range in the central Maryland region from 85 to 126 beds. And to give you some perspective, that is almost half of what the need, the total need is. So there's a significant unmet need for this service in the region. The applicant showed a commitment to serve the gray area population. In accordance with the standards, they had a fee scale, and they agreed to meet the requirement in the state health plan of providing at least 15% of their patient days to indigent and gray area population. And they plan to operationalize it with a daily tracking that would look at the payer mix of their population and allow them to make quick adjustments, real-time adjustments, if they were not meeting that standard. Project appears to be viable. The resources are clearly available to implement the project, and the projections show a positive bottom line. On impact, staff concludes that given the projected need for the additional detoxification services in the region, approval of this project would likely have very little, if any, impact on other providers, and it would improve the geographic and demographic access to alcohol and drug abuse treatment services. In summary, the staff recommends approval of this project. It complies with the applicable standards in the state health plan. It has been shown to be needed, viable, cost-effective, and have a positive impact on the healthcare delivery system. There are several conditions being recommended with it. One is that Baltimore Detox shall document the provision of a minimum of 15% of patient days to care for indigent and gray area patients by submitting annual reports, auditing its total days of care, and the provision of days of care to indigent and gray area patients as a percentage of total days of care. And such audit reports would be submitted to the commission following each fiscal year, starting in year one and continuing for 5 years thereafter. The second condition is that Baltimore Detox must receive preliminary accreditation by the Commission on the Accreditation of Rehabilitation Services prior to receipt of first use approval, and must timely receive final accreditation by that agency. Baltimore Detox Center's third condition, that they shall provide written transfer and referral agreements with a number of different providers on the continuum. I won't read all of them. At this point in time, they have those transfer and referral agreements with a hospital and most of the categories of providers on this list, but are lacking in about 3 categories, and they will need to complete those transfer and referral agreements. What the applicant told us, and we've heard this before from other applicants, is that some organizations are reluctant to go through the effort of arranging these agreements unless and until they know that the organization seeking them is actually going to materialize, which having the evidence of receiving a CON probably should provide those organizations with the assurance they need or are looking for. Fourth and final condition, Baltimore Detox Center shall provide written referral agreements with outpatient alcohol and drug abuse programs that meet the requirements of specific subparts of the standard in the state health plan. There are several representatives of the applicant on the phone line, including 3 of the owners, Mike Silberman, Mark Gold, Kabir Singh, Nick Albaugh, the executive director, Adam Strulitz, the general counsel for Amatus Health, Rich Coughlin of DHG Healthcare, their consultant, and Maggie Witherup, their counsel.
Thank you, Kevin. Do I have a motion to approve the certificate of need application filed by the Baltimore Detox Center LLC to establish an alcoholism and drug abuse intermediate care facility?
So moved. This is Casey Boyer.
Commissioner Boyer, do I have a second?
This is Marty.
Second.
I'll second.
Commissioner Hammerslaw. Discussion. I hear no discussion. All in favor?
Aye.
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 Any opposed? Very good.
Dr. Pollack, Commissioner Jordan, who's is on, his audio doesn't seem to work. He votes aye.
You wrote approve. Okay, good. Thank you. Congratulations. Your certificate of need is formally approved. Agenda item number 4. There's a change in the approved certificate of needs today to increase the approved cost for a project authorized previously by the Commission in October 2018. Brinton Woods Health and Rehabilitation at Winfield is a 60-bed nursing home in Sykesville in Carroll County. The Commission authorized relocation of this facility to Westminster and its replacement on a site at the Carroll Hospital campus in 2018. Kevin McDonald again will summarize the proposed project and present the staff's recommendation for the Commission. Kevin?
Thank you again. So this, as Chairman Pollack stated, this is a request to increase the approved cost of the project, which was originally approved in October of 2018 at a total project cost of about $14.8 million. At this time, Brinton Woods requests a $2.3 million increase, just under 16%, which would bring the total project cost to about $17.2 million. Brinton Woods and LifeBridge Health will fund the additional cost through cash. And the reason it's before the Commission is that it involves the projected or the requested change involves a capital cost increase that is in excess of the inflation allowance and thus requires Commission action. The applicant explains that the reasons for the cost increase, the original cost estimates were made without the benefit of final architectural design, were instead based on preliminary concept drawings. And they got the rude shock when the construction bids submitted being significantly higher than the estimates that went into the CON application. Some of the contributing factors they speculated is inflation of construction costs and changes in market conditions from October of 2018 until present. And site work uncovered unanticipated amounts of rock that needed to be demolished and removed from the site. Staff recommends, despite the cost increase, we believe that the proposed modification would not change the findings made by the Commission in 2018 because with no changes in the location, capacity, or nature of the project, staff concludes that the requested modification doesn't change the need for the project or its impact on existing providers. Although the cost in the total project cost is increase is significant, Brinton Woods and LifeBridge Health have documented the availability of funds for the project and will cover that additional cost with cash on hand. And from a public policy perspective, the cost increase would not result in higher costs to Medicare and Medicaid programs. Medicare reimburses prospectively with predetermined rates based on patient acuity, not on a cost basis. And its rates are established by geographic region and not facility specific. Therefore, staff recommends that the Commission approve the proposed changes to the certificate of need issued to Brinton Woods to relocate a 60-bed replacement facility and to maintain the same conditions attached to the original CON, which address the minimum level of service that must be provided to Medicaid patients. We have on the line from the applicant, Teresa Fletcher, the Assistant Vice President for Business Development at LifeBridge, Maurice Spielman, the Director of Design and Construction Management, and Marta Harding, their counsel from Venable.
Thank you, Kevin. Do I have a motion to approve the change in approved CON for Brinton Woods relocation of a comprehensive care facility? Did somebody say so moved?
So moved.
Second. This is Casey Boyer, second.
I have a second from Casey. I didn't hear the original motion. Did anybody get that?
Commissioner Metz?
Commissioner Hammersley, yes, I sent in a motion.
Excellent. So I have a motion and a second. Is there discussion?
I think so.
Hearing none. All in favor?
Aye.
Aye.
Aye. Aye.
Any opposed?
Dr. Pollack, Commissioner Jordan voted aye,
And O'Connor,
and O'Connor.
yes.
Excellent. So the change in approved CON is approved for relocation of the comprehensive care facility.
Thank you very much.
Agenda item number 5, confirmation of approved emergency CON, establishment of 32 additional inpatient beds at Mercy Medical Center. Yesterday, after conferring with me and the Office of Healthcare Quality, MHCC's Executive Director, Ben Steffen, issued an emergency CON to Mercy Medical Center to convert shell space on the 17th floor of its new clinical tower into 32 patient rooms. Commission regulations require that we confirm the issuance of the emergency CON at our next commission meeting. Staff sent commissioners the documents pertaining to this emergency CON, Mercy's application, OHCQ's letters that states reasons why action is needed, and the emergency CON. Mercy's told me that it expects to start the build out of the 17th floor very soon. Paul Parker, Director for Healthcare Facility Planning and Development, will present the emergency CON. Paul?
So very briefly, don't have really much more to add to the information that the chairman has already provided. And this is posted on our website. If anyone has not been able to see the CON, it's on the certificate of need page. About almost 10 years ago, Mercy completed a project that I would describe as close to a replacement of the hospital on site across the street from the existing hospital. They built a 18-story tower, and when approved, it actually had a lot of shell space. It was approved as a project that would be completed in phases. This actually made the project quite a bit cheaper than it would have otherwise been, and so we have actually gone back at least twice, possibly 3 times in the last 10 years to approve phased build out of that tower. It's now reached a point where they still have a top floor of shell space that from a plumbing and utility standpoint, I think has been stubbed for a nursing unit because that was a likely use of that. So the emergency CON would allow them to go forward immediately to complete that shell space as a 32-bed medical surgical unit. They estimate the cost will be about $12.5 million, and they will actually be able to fit out the space within about 70 to 75 days. So we are recommending that you confirm the action taken by the executive director yesterday and approve this emergency certificate of need.
Thank you, Paul. Do I have a motion to confirm the emergency CON for establishment of 32 additional inpatient beds at Mercy?
So moved.
Who was that?
O'Grady.
Wang.
Grady? And the second was from? Do I have a second?
Second.
Second.
Boyer.
Sorry, I wasn't able to hear. Was that Commissioner Boyer was the second?
Yes.
Okay, great. So I have a motion from Commissioner O'Grady and a second from Commissioner Boyer. Any discussion?
Hopefully they can go faster than 75 days.
You repeat the question?
Uh,
Dr.
Go faster than 75 days.
Commissioner O'Grady, I think they're told to proceed with undue speed. They were waiting for the CON document to come to them yesterday afternoon and said they would get started. They had people on standby waiting for this document to come. So my understanding is as
Yeah,
fast.
perfect. Good, thank you.
This is
All right.
Commissioner Sargent. I did just have a general question, and certainly I'm definitely a yes on this one. Do we have any estimate of how much need there is going to be in the state, or is it just too premature to even figure that out?
Well, when you look at the possible scenarios under this pandemic, the numbers can be pretty daunting. Under worst case scenarios, we may see a surge in infected patients that would really tax our existing hospital capacity. Obviously, the emergency measures that are being taken right now are aimed at slowing transmission, and hopefully, what's being used is flatten out the surge to some extent. So the delta between the best case and worst case scenarios is pretty large. We're hoping that we can flatten out the surge, and so that we can pretty much deal with the severe respiratory cases that could, under the worst case scenario, really overwhelm the system. We have significant amount of built space in hospitals, not all of which would be appropriate to put back into operation, but we anticipate that we will see a number of projects of that type. And we're already starting to, deal with some of those requests. But the worst case scenarios are pretty bad. And even this objective of 6,000, you can imagine, just from a staffing standpoint, what actually trying to bring 6,000 additional beds online in Maryland, it would almost seem to me to be a miracle if we could do that in any real way. But certainly 1,000 to a couple of thousand beds, that certainly seems in the realm of reality as something that we could accomplish. And I think under the best case scenarios, that might be sufficient.
Thanks.
Is there other discussion? I think that, as I said yesterday when Ben and I talked about this and earlier in the week, I'm completely in support of this. It's something we absolutely have to do. It's absolutely consistent with the rest of the department's efforts and the governor's efforts to increase bed capacity rapidly. But in order to get towards 6,000, and Paul's right, I think it's going to be difficult to get to 6,000, but to get towards 6,000, we're going to have to move a little faster than 32 at a time. That said, this is sort of relatively low-hanging fruit and something that makes infinite sense. The challenge for this one is going to be the ability to turn it down at the end of the crisis, because this will be built space within Mercy, and I think they understand that in order to keep it up and open, they're going to need to come back to us with a new CON application at the end. And I think we'll be more than happy to be at the end of this crisis, at the end of the declaration of state of emergency, and willing to take a look at that point. Do I have any further discussion on this motion? Hearing none. All in favor?
Aye.
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 Excellent. Any opposed? Hearing none. Mercy has its CON for emergency conversion of shell space to 32 patient rooms.
So, Dr. Pollack, one point that Commissioner Boyle is not able to speak, but she continues to be present. she said she was able to talk. All right, so she is reconnecting. Very good.
Got it. Thank you. All right, moving on. Agenda item number 6, our legislative update. Back to more mundane affairs. Megan Renfrew, Chief of Government Affairs and Special Projects, will provide an update on the legislative session. The session, as we know, came to an abrupt end this week, about 3 weeks earlier than planned due to the COVID-19 crisis. Ms. Renfrew will focus on the status of bills that were of particular relevance to the commission and that may or may not have passed this session. Ms. Renfrew, the floor is yours.
Thank you. Good afternoon, commissioners. As the chair said, I'm going to give a brief update on legislative activities. I did send a memo to commissioners on Friday with some detailed notes. A lot has changed since Friday, but I did want to point that out for audience members. That is available on the commission's website. So normally this week we would be talking about the crossover date, which is that first cross on the chart on slide 2. That's a major date in the legislative calendar, the date when bills cross from their house of origin to the opposite house. However, this week, as the chair noted, is anything but normal, and the legislature adjourned last night. This functionally condensed 3 weeks of work into 3 days. The legislature passed 650 bills in the last 3 days, so they worked tremendously hard to get this done so that everyone could go home and self-isolate. So the only step that is left for bills is that very last box in this chart, which is to go to the governor. It is expected that the legislature will reconvene in late May to take up urgent legislation related to the economy and to the COVID-19 crisis. The special session is not expected to be for bills that failed during this session or otherwise ran out of time, but it may include some veto overrides if the legislature feels inclined to do that. So this presentation, I'm just going to focus on bills that had relevance to the commission. Because the session ended yesterday, there's some bills like the budget bills that I haven't had, that are large and significant, and I haven't had time to analyze the final version, so I'll do my best to answer your questions, but I did want to note that we're still very close to the end. So with respect to our priorities, I really thought about MHCC as having 3 priorities this year. One was to deregulate state-owned facilities. That bill failed in committee. We've talked about that before. The second was to create a program for sharing non-controlled substance prescription records. That bill also failed in committee this year. I think we'll regroup and think about how we could approach that differently in the future, or whether the private market will just sort of solve it on their own. But we'll do some thinking about that. The third bill that is important to us, although I think not the same way driven by us, is the prescription drug affordability funding bill. That bill did pass, and it's important for us because we've been loaning the Prescription Drug Affordability Board, which is a new board, funding to start up their operations, and this allows them a special fund source to pay us back. So that's positive. With respect to the budget, that is probably the most important thing the legislature had to get done before they adjourned, and the budget bills did pass. We had a relatively easy year as a commission this year with respect to the budget bills. Our budget appears to be intact, and we weren't assigned any projects through the budget bills. That's normally a way in which we would get special legislative work, and that didn't seem to happen this year. So that's also a good thing with respect to resources and workload. Moving on to other bills of interest, we had a strong interest in a bill that related to Anesthesia, use of anesthesia and procedure rooms in ambulatory surgery facilities. We worked closely with the Maryland Society of Anesthesiologists to come to an agreed upon amendment, to negotiate an amendment that we could both live with on this bill. Those bills passed both on the House and Senate side, so that is moving forward. There was also a set of bills related to electronic prescriptions, requiring them for controlled dangerous substances. This would require use of electronic prescriptions for controlled dangerous substances on the state level. I think it's important to note that Medicare will be requiring this in 2021, so it's going to be happening for providers that provide services to Medicare patients, regardless of what the state did. But both bills did pass here. So moving on to the next slide, there was the Opioid Operations Command Center was attempting a bill that was similar to a bill we had tried 2 years ago to deregulate intermediate care facilities from CON that provide substance and alcohol treatment, and concurrently to increase BHA's oversight over those facilities. That bill did not move forward this year. I think the Opioid Command Center will go back to the table and think about what their next steps are, and we'll certainly support them and work with them as they do that. There was also a bill that we talked about related to loan repayment assistance for physicians and physicians' assistants working in primary care in underserved areas in the state. This moved the administration of the program to the Maryland Department of Health, which hopefully will help with its administration. And it provides for authorization of additional funding for 1 year for the program. As originally written, it was going to provide $1 million of funding moving forward, but now it's just $1 million of funding for 2022, and then all other years are at the same $400,000 that they've been in the past. But it does establish a work group to look at establishing a permanent source of funding for this program, which I think would then potentially allow for greater funding, depending what that source is. And our executive director will be required to sit on that work group. We had also discussed in one of our conference calls a bill related to a notice for outpatient facility fees. These bills waited right till the end, but then they moved, so they have passed. And this requires hospitals to provide patients with notice of an outpatient facility fee when appointments are made. It does not apply to ED visits, and it has a later effective date, so hospitals have a little over a year to prepare for this. But that has become law. We also, there was a bill this year, which has appeared for each of the last 3 years, about increasing our public notice for members of the public and also for elected officials with respect to hospital and freestanding medical facility closures and partial closures. This bill, again, did not move forward this year, but the vice chair of the House Government and Operations Committee did ask that we work with the sponsor on her issues. So I've reached out to her. Clearly, she had a very busy last few days, so we haven't heard back yet, but I assume that will happen. And then finally, there are a set of bills related to telehealth that passed. House Bill 1208 and Senate Bill 502 started out as very different bills. One of them was establishing a permanent program and the other one was a pilot program. They've ended up as essentially cross files with the same language in the end. So they create Medicaid coverage for mental health treatment provided at home. for Medicaid beneficiaries, and then also establish a pilot program for telehealth for Medicaid related to care management services. So that's definitely an expansion of telehealth under the Medicaid program. Obviously, we're seeing unrelated expansions of telehealth in all areas of our state right now for different reasons. But this is an interesting project. And then House Bill 448 and Senate Bill 402 have to do with telehealth regulations that came out from the Board of Physicians last year that prevented use of asynchronous telehealth, and some providers had pushed back against that. So these bills allow use of asynchronous telehealth in the state of Maryland. Also, and then finally, there are a set of bills that related to health insurance mandates. We talked about the cost of health insurance mandates in the fall. That's something we study as a commission. This year, some existing health insurance mandates were expanded. So the prostate cancer screening mandate, which already existed for the private health insurance market in Maryland, was expanded to prevent cost sharing for consumers, and the in vitro fertilization mandate, which again already existed in Maryland, was expanded to cover unmarried individuals who wish to have a child. And then a new mandate passed for pediatric autoimmune neuropsychiatric disorders. So that is a quick summary of highlights of bills. Given that the session just ended yesterday, I will be continuing to analyze what has come out of the session and working with staff here to make sure we're prepared, both with respect to the policy bills we covered today and then also bills that affect our ongoing administration as a state agency. So any questions about any of the bills that I could answer for anyone?
The questions for Megan. Megan, is there any clarity around the question of whether there'll be another session later to address some of the leftover issues or to address any of the emergency issues attached to this state of emergency?
So I think I only know what probably the rest of you who read the news regularly know. So what they're saying right now is there probably will be a session in May, late May, to address issues related to the emergency, issues related to the economy, and any veto overrides that are come out. The governor now has a period of time to review bills and decide what action he's going to take on them. I think what is important to note is that is not a regular session, and the bills that failed this year probably will not be addressed during that session. They'll have to wait and start the process over again next year.
Understood.
Yep.
Any other questions from any of the commissioners? Do I have a motion to approve the legislative update?
So moved.
Thanks.
It does say action.
It does say action.
Second.
That's a
I think it's
legacy.
Commissioner Reimer and second from Commissioner Sargent.
Hey, this is
All right.
Marcia. Can you hear me?
Yes,
Yes.
Oh, good. I'm back. Good. Thank you.
welcome back. All right. All in favor?
Aye. Aye.
Good. Anybody opposed to Megan's legislative report?
So
Hearing none.
tempted, but
Hearing none. Thank you, Megan. We appreciate all your hard work throughout this session. Agenda item number 7 is a presentation on Maryland Nursing Home Family Experience. Since 2007, the Commission has administered an annual Nursing Home Family Experience of Care survey. Maryland is one of the few states that administers a survey designed to objectively assess consumer satisfaction with nursing homes across the state. The 2019 survey process is now complete, and Stacy Howes, Chief for the Long-Term Care and Health Plans Quality Initiative, will summarize the survey results. Stacy?
Good afternoon. Thank you. As you said, I have the results of the 2019 Nursing Home Family Experience of Care survey to share with you. Next slide, please. So this survey is designed to elicit levels of satisfaction with a loved one's care throughout Maryland nursing homes, and it's for long stay residents only. We survey responsible parties. It's typically a loved one or a family member, but occasionally it's a friend or a neighbor. We use the results to evaluate the quality of care and performance of Maryland nursing homes, and also the scores are used in the Maryland Medicaid Pay for Performance program. Next slide, please. So this survey was first tested in 2005, and as you said, it was first administered in 2007, and we've administered it almost yearly since then. Next slide, please. And in 2016, our contractor for the survey did an analysis and determined that there were quite a few information gaps in our survey. So starting with the 2018 survey, we made several substantial changes. We added 13 questions based on a scientific literature search, what a few other states do, and the nursing home caps. So as of 2018, we have a total of 37 core questions. We use 31 of them to calculate 7 domains. We have 2 individual items that we measure, and then we have 4 screening questions that don't go into any calculations. And then we have 11 demographic and background questions. And in 2018, we added a Spanish language version as well. So this year, all 223 nursing homes participated. And of the loved ones who were surveyed, we had a 43% response rate. So like I mentioned before, there are 7 domains, and that includes the staff and administration of the nursing home, care provided to residents, food and meals, autonomy and resident rights, physical aspects of the nursing home, activities, and security and residents' personal rights. The domains in bold are brand new domains as of 2018. And we have 2 individual items that we measure, the overall rating of care and the percentage who definitely would or probably would recommend that nursing home. We also calculate peer groups, including the region of the state, the size of the home, ownership type, and the payment source. So here on your screen, you see the statewide scores for 2019. The first 7 rows are the domains that I mentioned just a few minutes ago, and those are all on a scale of 1 to 4. The second from the last row is the overall rating, and that's on a scale of 1 to 10. As you can see, all of these scores are in the good range. Next slide, please. Thank you. This is because we have been conducting this survey for several years. We have several domains that we can trend over time. So here are the 4 domains that we've been collecting data on for several years now. As you can see, for all 4 of these domains, there is a downward trend. And for staff and administration, care provided to residents, and the physical aspects of the nursing home, the 2019 scores are statistically significantly lower than each prior year. For autonomy and resident rights, the 2019 score is statistically significantly lower than each prior year except 2018. Next slide, please.
Can we ask questions?
Sure.
So what's your thinking behind what this downward trend in, consistently across all 4 measures? What's your thinking?
I am going to get into that. Do you want me to talk about it now, or?
I think it's, given we're all on the phone, I think I wouldn't mind if you talked about it now, just because the idea of, talking about it at the end and, are we all going to flip backwards and things like that. If you don't mind taking, I don't mean to slow things up, but I think it would be more comprehensible if you talked about it now.
Sure. There are quite a few. Well, these aren't the only sections that decreased. If you can skip ahead, if I can just go through the next couple of slides and show you those.
Of course.
Right. Explain. So the next one shows the 3 domains that were added in 2018. Food and meals, the 2019 score is statistically significantly lower than the 2018 score, but for activities and security and residents' personal rights, there was no difference between the 2 years' scores. And then if you go to the next slide, you see another decrease in another part of the survey. So this is the overall rating, and you can see a slight decline over time. And again, 2019 is statistically significantly lower than each prior year. So if you go to the next slide, you'll see the same trend for the last individual measure, which is the percent recommendation. Sorry, the percent who would recommend this nursing home. And you see a clearer downward trend. And again, 2019 is statistically significantly lower than each prior year. So there's a couple of things that I've done to examine this. Well, first of all, let's look at this slide. For all 7 domains, the overall rating and the percent recommendation, the state score was significantly lower than Western Maryland, the Eastern Shore, small homes and not-for-profit home scores. The state score was significantly higher than Southern Maryland, large homes and for-profit home scores. So if you go, let's see what's on the next slide. So here's where I start to tell you a little bit more about the analyses that we've done to probe the data a bit more. So because this is concerning that all of the scores are going down fairly steadily across the entire survey, we looked at a few things to make sure there wasn't just some artifact of the data. And we found that we reconducted the analyses based on the 2016 criteria, and the results were exactly the same. We also completed an item analysis and found that the patterns of responses were consistent with an incremental decrease. So what that means is that the responses shifted from always to usually to sometimes. They were not drastic drops from always to never. And we found the pattern in virtually every item. So if you go to the next slide, last year was when we first noticed the decrease. And so I reached out to the nursing home community to find out what they thought was behind the decrease in scores. And so I presented this last year. I just wanted to show you what people were thinking, and I don't think this has changed. And I heard back from 18 people in the nursing home community. And what they said is they feel like families and residents are more educated. They are well-versed in the 5-star rating system and in regulations, and they immediately notice any decline. Also throughout the industry, it seems to be generally accepted that both baby boomers and their children are much more demanding than previous generations. Also, long-term care employees, it's thought that they have less time with to bond with patients and families than they did in the past. That's how they feel. And also, long-term care is not always seen as quite as appealing as doctor's office and doctor's offices and hospitals for employment, and that might be contributing to low employment rates. And also there have been quite a few Medicare and Medicaid changes over the years, and that influences staffing. Also, quite a few people mentioned that they feel like they're spending significant time addressing regulations instead of patient needs.
Okay. Now that's a little bit, I am going to say that was a little grain of salt. I assume we all are, because that's the answer coming back from the industry.
Exactly.
At the same time, you showed us that this is not, that we have these pockets where this problem, that it's not a problem in Western Maryland, but it is in Southern, and it isn't among the nonprofits, but it is among the for-profits, and it isn't among the little guys, it's among the big guys. So to a certain degree, the idea that there's been Medicaid changes or something else like that, or I have to say I'm a little tongue-in-cheek on an idea of that. I mean, it's a very good thing that families are more prudent consumers of their health care, but it's sort of like to say our industry is going down, but it's our customers who have changed, not us. that's I have to say I take that with a much bigger grain of salt. That somehow it's the consumers have changed, not the products being provided. So I guess I'd like to know then, I mean, that all makes sense and it still looks like a fine analysis. What do we think the follow-up is in terms of trying to figure out what it is this commission can do to change this trend?
Yes. So if you skip ahead to one more slide.
Sure.
So this is what we are attempting to do right now. We're reaching out to the industry and community. So in the industry, we are reaching out to QIO programs and the Department of Aging to see what it is we can do to help improve satisfaction. Also, this survey is administered every single year, and we share this data with all of the nursing homes. They get a detailed, comprehensive analysis report on their scores on this survey. As for the community, we also share the results for every nursing home on our long-term care consumer guide in a consumer-friendly format. And as I mentioned before, we added a Spanish version of our survey, and next year we're going to add an online version of our survey to hopefully get some more voice into our survey. Also, I am in the process of integrating types of data sources in order to inform our understanding of data patterns and see if we can identify any areas of potential improvement. And as always, our center is always working to increase public awareness and the availability of our data and reports by putting them on our long-term care website.
Got it. Is there any ability to do a follow-up with any of these people? You know, people who would have answered the survey a year ago, 2, 3 years ago, and kind of to get a feel for where they are now and what may have changed? I mean, just a small subsample, just to get that idea of follow-up I mean, I'm just thinking about it, the things we can capture through a survey instrument that will help target where the real problem is. I mean, I think you've done a very nice job here of doing, you know, size and part of the state and et cetera, and those kind of things. But I think it's also a question of, I mean, if the pushback is going to be the consumers have changed, not the services we're providing are worse, then it would be good to have a stronger set of data, a better kind of follow-up process to be able to link, you know, somebody's response in 2018 to their response in 2021.
That's an excellent idea. I'm going to look into that. Thank you.
This is Commissioner Metz.
Yes.
Yeah, I obviously have a little bit of background in this area. Very familiar with the survey. Our facility has done traditionally very, very well on this survey. You know, a couple thoughts to piggyback on what's been said here. And I want to thank you because I know this is an incredible effort that's undertaken each year as we go through this process. You know, a 40-some% return is not bad considering how detached at different times members of our society are. But you know, a couple thoughts, you know, pop into my mind. I've been doing this for 26 years. The population that we serve has changed over those 26 years significantly, but I cannot say that the quality of care that we've delivered has increased or decreased. The level of regulation has exponentially increased. Reimbursements changed multiple times over the years, typically an effort to reduce reimbursement while asking providers to do the same level of care. That's always the initiative. It doesn't always pan out that way, but it's typically the way it ends up being. There was a significant change in Medicaid reimbursement over to a case mix index type of system over the last couple of years that could have played maybe a little bit into this, where some facilities would see higher reimbursement, some would see significantly less reimbursement, depending upon the case mix within their facility. But one of the things that I can't help but think about that I've seen over the years is the number of smaller facilities and locally owned and privately run facilities, or the mom and pops, if you will, disappear and be bought up by large corporations. And I have to wonder at different times, our facility is still, you know, locally owned, very small, if that has impacted the care provided as facilities have moved away from singular owned facilities where the owner operates the facility and pays particular attention to the care provided versus the large, and I'm not saying that the large entities can't provide quality of care, obviously they can, but I have to wonder at times what impact that's had on the care delivered in our nursing homes. So be interested to see a follow-up as Commissioner Grady has suggested as far as a smaller subset to see what they believe may have changed over the last 3 years. But anyway, that's my comments. Thank you for your work.
Thank you.
Are there other
Hi,
comments?
This is Commissioner Boyle. It's a great survey, and I think the comments that have been made, I completely agree with. But given some of the ones, Southern Maryland, that didn't do well, and given the crisis right now with COVD and what happened in Washington State, I'm sure this information is being shared with the appropriate agencies, but what steps are being taken in Maryland to make sure the vulnerable populations in our nursing homes don't go through what happened in Washington State?
I can speak to that a little bit. Well, actually, I could speak all day about it. The steps have been taken by CMS in the state of Maryland have been significant. Basically, the facilities in Maryland are restricting visitors completely, except for end-of-life care situations, in which case family members would have to go through stringent infection control guidelines upon visit. All employees are being screened daily. All residents are being screened daily. There's no outside activities coming in. All service deliveries have to come in through different sections of the facility that don't come into the populated areas. No activities, communal activities or communal dining among residents. So pretty significant steps, things that we have done many times in the past, although not to this extent with influenza outbreaks in general. The Washington case state is, just a case study in what can happen in a facility if a virus such as this nature comes into a facility undetected. Nursing facilities don't have respirators. Nursing facilities don't have the types of ventilator care, et cetera. And oftentimes, we work within an industry that is chronically looking for additional staff, let alone in the middle of a crisis where a facility may have a new virus that's unknown to most of the folks working with it, at least at the beginning. So, but to kind of answer your question there, Maryland nursing facilities have really stepped up over the last 2 weeks with regulation changes and guidelines, sometimes hourly, but definitely daily. So the response has been pretty significant, at least in Western Maryland. So I'm hoping that, facilities throughout the state are following those same guidelines as seriously as we are.
Well, that's great. Thank you. But Western Maryland sounds like you've got your act together. But when you say you hope the others are following that, that's not a statewide policy? Yeah,
it's a statewide policy. It comes down, it's a federal and state policy.
Okay.
CMS is issuing guidance on this. So they should be following this to answer your question. So if they're not, they'd be blatantly out of compliance. But yeah, they should be following the guidelines from CMS and the state of Maryland. And they're very strict. Thank you.
Thanks.
This is Commissioner Boyer. I have a question.
Go ahead.
So were there any outliers, any locations that did exceedingly well when the survey, or was it pretty homogeneous responses?
Yes, the areas that did better than the state average are in the top box. So Western Maryland and the Eastern Shore are the parts of the state that had the higher scores. And then smaller.
So it wasn't to a specific facility?
I'm sorry?
Was it to a specific facility?
It's these are the regions of the state compared to the state.
Correct, but what was the survey done in a way that you could identify what specific facilities are doing better?
Oh, yes. I'm sorry. Yes, I can. I don't have that information with me, but I can definitely look it up and provide an update.
I think that would be helpful, just to see if there's a way to even go in and see if there's some lessons learned or best practices that could be shared with others.
Okay.
Anyway, I know that that particular industry is pretty connected to each other, but I think having an organization such as the Maryland Healthcare Commission being able to make that connection for them also shows that we do care and we are looking to improve the situation, and it is important to us.
Thank you. I will follow that up. Thank you.
Stacy, this is Ben Steffen. Did you have a chance to visually or through a data analysis compare 5-star ratings to patient satisfaction scores?
Yes. Yes. If you'll go forward a few slides, I ended up having to skip that one. This one right here. So, go back one.
That's what I'm looking. I have that.
Okay. So it would be ideal to be able to compare the Maryland scores to nationwide scores. Unfortunately, there is no nationwide family nursing homes experience of care. So I compared our scores to the handful of other states who do a similar type of survey. And so Rhode Island, Minnesota, and Ohio and Oklahoma do a similar type of survey. It's important to keep in mind that they do not we are all using different surveys, so this is a very high level comparison. Rhode Island is also decreasing, like our scores are decreasing, and it's also incremental small bits. It's decreasing just like ours, and Minnesota seems to be increasing over time, while Ohio and Oklahoma are remaining steady. So we have that comparison, and then I also compared our state scores to the CMS stars. And what I found is that all 7 domains on our survey, the overall satisfaction measure and the percent who would recommend the nursing home measure, was statistically significantly and positively correlated with the overall star, the health inspection star, and the staffing star. 3 of our domains, the overall satisfaction and the percent who would recommend the nursing home, was statistically significantly and positively correlated with the quality star. So what that means in a nutshell is that as our satisfaction scores increase, our CMS stars increase, and the opposite is true. As our satisfaction scores go down, our CMS stars go down. So this is something to be concerned about.
Thanks.
You know, one thing, Commissioner Metz, one thing final I'll say, you know, with dealing with the coronavirus outbreak and taking a look at, you know, the Washington State example, which will continue to be an example forever. You know, I really feel for that facility out there because I know that it had that mysteriously come into our facility. I'm not sure the outcome would have been any different. And, you know, our facility is one of the highest ranked facilities in the state because, you know, such a new virus within the environment we operate in. You know, we're doing the things that is recommended to prevent that from coming into our facility. But if you read the literature on how many cases we're going to have in the American population, let's hope that doesn't happen. But we're talking about multiple hundreds of thousands of cases. It will come into nursing homes. I'm hopeful that we can have a different outcome.
Thank you. Are there additional questions? Hearing none, thank you very much, Stacy, for that report.
Thank you.
Before we move on to agenda item number 8, the overview of upcoming activities, I want to turn the commissioner's attention to the report that went out with the materials that didn't get included on the agenda because we were concerned about time in the first teleconference meeting. But the agenda item was interpreting national hospital rating systems, and Courtney Carta had put together a nice slide set to outline her presentation. I encourage commissioners to go through that. In particular, the chart on the back end, the characteristics of rating systems, I think can be extremely valuable as a long-term resource to help people understand what types of information different rating systems provide. So thank you very much to Courtney for all of her work in putting that together. And hopefully we'll have an opportunity at an upcoming meeting to go through that. Hopefully it'll be in the context of a less significant emerging threat to us. Moving on, agenda item number 8, the overview of upcoming activities. Ben, would you like to share the upcoming activities for April's public meeting?
Yes, the agenda is more tentative than usual, which says a lot because at a month out, our agenda is always a little speculative. We hope to have 2 longstanding CON applications to you, as well as a action on a new certificate of conformance. We will also be reviewing with you some changes in our Health Information Exchange regulations and a spending report on the privately insured. I would want everyone to know that there may be needs I need to have a phone conference call to cover several administrative matters that could come up. We'll keep you posted on that as a month progresses. And obviously, we're in a very uncertain situation with the progression of the virus, and everyone should act cautiously, and we will also do the very best to protect our staff while also keeping them fully engaged.
Thank you, Ben. Unless other commissioners have additional items to discuss, I'll entertain a motion to adjourn at this time.
So moved.
I believe that was Commissioner Hammerslaw.
Commissioner
Boyle, but that's okay.
Boyer, okay, all right. Doing my best. Is there a second?
Boyer, second.
Okay. All in favor?
Aye.
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 Any opposed? Hearing none. Thank you, everybody, for your attention today and for all your preparation, and a special thanks to the staff for putting together the online meeting. Have a good day.
Thank you very much.
Thank you.
Thank you.
Okay. All right. Thank you, everyone.